toxicity management in kidney cancer is probably one of the most important aspects to a successful outcome for our patients. Yes, the drugs do the work and they make a difference, and they can shrink the cancer and they can prolong the survival, change the natural history, and it's wonderful advancement that we've seen mechanistically from now several agents in the field that have been approved for kidney cancer. But if we can't manage the toxicity in these patients, it's a hollow victory. And I've had patients where we've seen the tumor regress, but the patients have been so damaged by the therapy that the quality of life is almost not worth the disease control that we achieved. So to me, recognizing up front the importance of this tolerance is critical, and helping the patients realize that this is going to be probably as big a factor in terms of their satisfaction with the therapy over the next 2 to 5 to however long they have to live. So that's a really important aspect to it. And then with each agent, it's different. And it's even different within the different TKIs. And we may say these, one TKI has a comparable side effect profile to another, and that's true. But on an individual basis, I'm going to see different profiles with these agents. So let's take cabozantinib, for example. One of the things we see with that agent is a lot of elevations of blood pressure, and some of them can be pretty significant. So that's important to recognize. It's an on-target effect. It's something we see. It's a class effect. But recognizing that that's going to take a proactive approach, and it's going to be a proactive approach that's a different pace than what you say the primary care might do. Primary care managing blood pressure might make a change and see you back in 2 months. Well, we're going to make a change and see you back in 1 or 2 weeks, because this blood pressure issue is likely to get worse rather than better if this isn't making an impact. And we'll need to be more aggressive in going up. With cabozantinib, I can do that because it's constant dosing. When I use a drug like sunitinib, it's a little trickier because we have these built-in 2 weeks or 1 week breaks. And so we kind of go up, but we don't want to overshoot and end up with hypotension on the off period. So I'm more aggressive with my hypertension management when I have a drug like cabozantinib, especially early on, and I know that drug is going to continue to build up in their system because of the long half-life. Diarrhea is another one. Diarrhea is thankfully with diarrhea, it's slow onset. So with some of our drugs, say like axitinib, half-life is so short, they get up to steady state within a matter of days. Diarrhea can really get ahead of patients quickly. But we can hold drug and we can wash it out pretty quickly. With cabozantinib, it's going to be a little slower onset, but when I hold drug, it's not going to wash out as quickly. So I'm more likely to, again, use my Imodiums and my Lamotals and other drugs to control that a little more aggressively. Even if it ends up stopping them up a little bit, I know I can back off on those medicines and things will come back again. So helping patients recognize, and even thinking in our own mind how not all these drugs are alike, got to think about the half-life, the pace, and the tolerance of these. Now, one of the things I like to do with dose modifications is interruptions. And I like interruptions because they allow me to maintain that full dose when I restart. And I can do interruptions for any length of period of time. I can do them for 2 weeks, or I can do them for 2 days. And if I do them early, I can do them for 2 days, and I can get back on drug. And again, it's not going to pile up too quickly on it. So to me, when I'm managing a toxicity, if it's starting to build up quickly in the first 2 to 4 weeks, I'm going to use dose interruptions during that period of time. Even with a drug like sunitinib, where I know I'm going to use a dose interruption at 4 weeks, I'm still going to interrupt earlier for shorter periods if I'm running into significant toxicity in the first 4 weeks. I'd rather do that, and then if I have to, when I restart, I still have toxicity, then I'm going to lower dose. But for the most part, I'm going to use my interruptions early, and I'm going to use my dose reductions slower, because once I dose reduce, I'm probably not going to go back up again. So to me, it's really important to recognize there's no downside to some dose interruptions during those first 6-week period. But once I commit down to a lower dose, it's really hard to get back up again. So that to me, those are some of the really key takeaways that I can give other people from the experience of treating hundreds of patients with these drugs versus folks that maybe have only treated a handful of folks.